Hello everyone, and welcome to the Army of Women Researcher webinar series. My name is Nikki Larita. I am the Research Manager at Dr. Susan Love Research Foundation, and I'm thrilled to be hosting this session today. Before we get started, I'd like to thank everyone for joining us. Thank you, Dr. Su and Dr. Su's team, for taking time to teach us about the work that you've been doing. Unfortunately, Dr. Love is under the weather today, but I am so excited to welcome Leah Eshraghi, our Clinical Research Director, to today's webinar. For our members who are unable to make it, we're going to provide a recording of today's webinar on the Army of Women website. Today we're going to have a conversation with Dr. Su about the Women's Health Survivorship Care Plan Study. Today's questions will be facilitated by Leah, again, our Clinical Research Director. Before we get started, I'd like to take a moment to introduce our researcher. Dr. Su is an assistant professor at the University of California, San Diego. She is a reproductive endocrinologist and epidemiologist who conducts patient-oriented research that focuses on reproductive outcomes after cancer. Dr. Su has led national recommendations on menstrual, endocrine, and ovarian markers of reproductive aging in the context of cancer and cancer treatment. She developed the Onco-Fertility Program at the University of California, San Diego, and has led an effort to disseminate guidelines of fertility preservation treatment throughout the San Diego region. As the director of the Onco-Fertility Program, she provides and directs fertility preservation consultations and reproductive health care of young cancer patients. Because of these research and clinical expertise, Dr. Su is uniquely poised to be a successful collaborator and contributor to policy initiatives relevant to breast cancer survivors. I have a few housekeeping items to cover about this presentation and the GoToWebinar platform. First, if you have questions throughout the webinar, please send them to us through our Questions tab, which is located at the side of your screen. We'll have time at the end for questions, and we'll make every effort to answer as many as we possibly can. Finally, a recording of today's webinar will be available shortly after our call. And with that, Dr. Su, you can start your presentation.
Great. Well, welcome everyone. We are here in San Diego where today it's still 75 degrees, so we welcome visitors. And I'm hoping to spend the next 20 to 25 minutes showing you what we've been working on, why we've been working on it, and what some of our observations were. And then we are more than happy to answer any questions or get feedback on the study that we did, which is called the Women's Health Survivorship Care Plan Study for Young Breast Cancer Patients. So the goals of today are to talk about why we did the study, to show you our clinical trial results, to spend some time thinking about what our future directions are, and to open up for discussion. So we know that reproductive health care is really needed throughout the cancer care continuum. And so the idea of the cancer care continuum is that as young women, we go through prevention, then there is, in some of us, detection of cancer, diagnosis, treatment, and then a long time in survivorship. And the red is to depict that for reproductive health needs, which we are specifically addressing fertility, contraception, pregnancy and offspring health, and sexual health, these needs really occur from the very start of diagnosis all the way into survivorship. But how do we deliver this care? So the rationale is that when a young breast cancer patient undergoes chemotherapy and endocrine therapy, that she can experience hot flashes, have fertility issues, sexual health issues, and for the first time, really very limited birth control options. We also have done some qualitative research leading into this project, and I thought that this is a good quote for us to start with. This is a 23-year-old adolescent cancer survivor, and she said, I think that there's a big gap also in the issue for care for fertility issues. So I don't see the oncologist that I went through for my treatment anymore. I have a general practitioner and my gynecologist. I think that between those three, there's like a huge gap in, I don't know if it's knowledge or just what you're supposed to tell someone who's been through what I have, or the differences between doctors. So it's really the idea that there's a lot of information, particularly for breast cancer patients, on how do we look for and manage these four reproductive health issues. But if the patient, if the provider, whichever providers you see, don't have this knowledge or don't know where to refer for this care, then these types of data really help nobody. So it turns out that there are some guidelines for cancer survivorship care planning. The Institute of Medicine in the US had said back now more than a decade ago that every cancer patient who finishes treatment should get a summary of what they were treated with, that's the treatment summary, and a survivorship care plan to help improve care coordination, inform us about the effects of cancer and treatment, and help guide follow-up care. After that, there are a number of general, we're going to call them SCP-R, survivorship care plans, that have been developed through big professional societies like the American Society of Clinical Oncology and others, and they can be online. But we found that very general SCP-Rs have inadequate reproductive health guidance. So because of that, we set out to do three things. These were the aims of the study that was funded by the California Breast Cancer Research Program. We wanted to develop a prototype for a SCP that targets the symptoms of estrogen deprivation, so those are hot flashes, vaginal dryness, vaginal symptoms, fertility concerns, contraception, and sexual health in young breast cancer survivors. Then, once we developed what we thought the educational materials should be, we wanted to be able to pilot this with the stakeholders, with the recipients. And so this would be our young breast cancer survivors and the healthcare providers who take care of them. So to this end, we did multiple focus groups with 37 young breast cancer survivors and 9 healthcare providers that ranged from oncology providers, advanced practice nurses, to gynecologists, to primary care physicians. And once we had this web-based tool, which I'll show you some screenshots for in terms of examples, then we wanted to test it in a randomized clinical trial to say, hey, did access to this educational material improve at least one of these 4 symptoms for a young breast cancer patient? Because we knew that it would be important to engage healthcare providers, we also recruited a nominated healthcare provider for each breast cancer patient who became a participant in our study. And our goal was to get about 196 young breast cancer patients and their healthcare providers. So this is a conceptual model, and all that's really saying is that we think we can build this SCP-R intervention, which is the web-based educational materials, plus with some text messaging support. We think that this can impact young breast cancer patients to appraise what reproductive health issues that they have. Because we gave actionable steps in our intervention, we thought that the young breast cancer patient, if the materials are any good, would undertake some action. And undertaking that action would lead to an improvement in our outcomes of interest. We thought that if healthcare providers here in blue can access the same information as their patient, that will also allow the healthcare providers to appraise the reproductive health issue of his or her patient, and then that there are some actionable steps that they can undertake to support their breast cancer patient. And this is a secondary pathway to try to improve these symptoms in this population. So the primary outcome of the trial was to say we wanted to, these are our participants, I'm sorry. So we wanted to intervene on young breast cancer survivors who have a reproductive health issue. So if you don't have a reproductive health issue, you don't need to go through 6 months of being followed in trial. So a reproductive health issue was defined as if you had at least 4 hot flashes per day, and at least 1 is moderate in severity. You had symptoms as measured by the vaginal atrophy symptom scale. You had reproductive concerns about pregnancy, and this is measured by a scale that we developed here and validated at UCSD called the Reproductive Concerns After Cancer Scale, or that you had a contraception need, meaning that you are at risk for unintended pregnancy because you're not intending to get pregnant right now, and either you're not on birth control or you are using a less effective method for preventing pregnancy, like withdrawal. So patients who had any of these symptoms could come into the study, and we were hoping that the primary outcome would be better in those people who received the SCP-R intervention as to the control. And the primary outcome was an improvement in at least one of these 4 issues. So that the hot flash measure improved by at least half, that the vaginal symptom score improved by at least half, that for people who are not trying to become pregnant, that they use highly effective methods of birth control, or that measures of fertility concerns went down to low, as scores of greater than 3 are considered moderate to high. So we wanted to give some screenshots of what the intervention material looks like. So a young breast cancer survivor who wanted to become a participant would come onto the website, as some of you did, and once you logged in and you completed a questionnaire for us to figure out whether you had met one of the inclusion criteria for reproductive health need, then you were randomized to either accessing all of the materials, as what I'm going to show you here, as opposed to only the resources. So essentially, if you were assigned to the intervention group and you clicked on hot flashes, this is what you would see. You would see, hey, welcome to the hot flash section of the Women's Health Survivorship Care Plan. This section has 4 areas. First is a very short version of the treating hot flashes skip, and this can be printed out as a 2-page PDF. We also thought that for patients who really wanted, or their healthcare providers who really wanted to dig into, well, why are we making these recommendations? What is the evidence? What are the data that support it? Then that was in this tab, where we had really culled through the whole literature up to, I think, the middle or late 2015, summarized it, and had hyperlinks to papers that were basically driving our recommendations. Next, what do clinical guidelines say? So it turns out that lots of professional healthcare societies have guidelines on how to manage hot flashes in young breast cancer survivors. So this tab would have gotten you to the name of the society and a hyperlink to that guideline, and that's very helpful for clinicians like me. And then finally, a resource page. So what we did was we culled down to a small number of resources that we felt could give young breast cancer patients and their providers pretty reliable and specific information on how to manage hot flashes. And so we had essentially this kind of setup for hot flashes, vaginal symptom sexual health, contraception, and fertility. So this is the example for hot flashes. And if you click on it, the short version of the skip, this is what you would have seen. This is a 2-pager where the first page is in a question-answer format. What are hot flashes? What types of hormone-free treatments will improve hot flashes in breast cancer patients? What type of hormone treatments would improve hot flashes in breast cancer patients? Actionable steps. What are some less invasive and more invasive ways in how do you move forward? And what we felt was a key 1 or 2 online resource. And we told you when we last did this review, so you know how current the information is. This is what the controls got, which is a list of the resources that we curated, and we divvied up for what was geared towards survivors, and then what was geared toward healthcare providers in the setting of like what type of information is here, and where does this information, what organization provides this resource. So now I'm going to go through the results of the study. We enrolled 182 young breast cancer patients in this 24-week trial, and very thankfully had 97% complete the trial. And if you're in the clinical trials business, you know that this is a really, really high retention rate. So we assessed online 318 participants, and we excluded 121, 99 because they didn't meet inclusion criteria for symptoms or for type of cancer or age. But among those who were eligible, a very small number declined to consent, that's 22, and then a few others failed the text message run-in, or they didn't provide the enrollment questionnaire. So we enrolled 197 and randomized 182. And they got randomized to half undergoing the intervention, that's 86, and half undergoing standard of care resource list. And you might notice that the numbers are not exactly the same in both arms. And we can talk about this in any detail, as my background is as an epidemiologist, but essentially it's because we stratified randomization so that you had equal numbers of women by age, by time out since cancer treatment. So it is very typical not to have the exact same number in both arms when you stratify randomization. So then patients who decided to become participants were followed up at 12 weeks, at 24 weeks, and the number that did not follow up was very, very few at each of these 2 time points for both arms. So ultimately, we were able to analyze everybody in an intent to treat analysis. So we are very thankful for the collaboration with the Army of Women. Of the people who completed the eligibility screen, half of them came from Army of Women referral. So this was 152 of about 300 women. Of those, 109 women who were half of the Skipper participants came from Army of Women, and 89 of these women, so about 49% of Skipper participants came from Army of Women referral. So thank you very much for your interest and support. This is what we saw on screening. Most participants, so what you're seeing is the proportion of participants, so they're enrolled in the study, who had fertility issues, hot flashes, vaginal symptoms, and inadequate contraception. And the gray is for the whole group, and then the pink is for the intervention group, and the green is for the control group. The point of this is to say that for every one of these symptoms, essentially about at least half or more met criteria for having this issue currently. The second point of this is to show you that the distribution is the same really between the intervention and control group, meaning that it wasn't that the intervention group was stacked high for people with fertility concerns, because you see these bars are very similar across issues. The final point of this graph is to say it's only about a third of women who had one issue. Really, 70% of women had at least 2 of these issues as a part of their survivorship experience. This is a table that describes the overall demographics of our participants. So the overall number is 182, and again, 86 in the intervention group and 96 in the control group. The half of our participants were 40 and younger, as you can see here. 86% were white, 5% were Hispanic, 89% were in partnered relationships, 89% college graduates, and income of greater than $51,000 per year. And without showing you the p-values, really the proportions were well distributed and similar between the 2 arms of the trial. This table describes the cancer characteristics of our participants. So at diagnosis, because half were younger than 35, most people were within the first 2 years, and then about a third greater than 5 years since diagnosis. As you would expect, pretty much everyone got surgery and chemotherapy, and a lot underwent radiation. Hormone therapy was in about 2/3, so this we expect of a young breast cancer population. And then that very few people had in situ disease, and pretty well spread among stages 1, 2, and 3. And again, this distribution looks the same between the intervention and the control arms. So then let me show you guys what we found. So the first question is, were the participants in the intervention arm more likely to improve in at least one reproductive health issue than participants in the control arm? So in the intervention arm, about 70% of the participants met criteria for an improvement, as opposed to 55% in the control arm. This odds ratio is 1.82, and that confidence interval is 0.99 to 3.4 with a p-value of 0.057. So this is to say that the folks who are in there, so we talked about this already, that this is not statistically significantly different between the 2 groups by this p-value of 0.057. But it's pretty close. So next, what we want to show you is by individual symptoms, how patients and participants fared over the course of the study. This initial slide includes all 182 women. What I'm going to show you in each of the subsequent slides is a sub-analysis That means that for hot flashes, we took those participants who had greater than 4 hot flashes, at least one in moderate in severity, and then looked at how they did by arm, by assignment to arm. So this was the mean hot flash score. Control is in blue, control is in red, and the treatment group is in blue. So this is to say, hey, at the start of the study, which is here, week 0, their hot flash scores look similar between the two groups. Over the course of 24 weeks, the treatment arm, the intervention arm, did better. Their hot flashes decreased a little bit more than the control group, but this was not a statistically significant difference. So what we see is about 60% in the intervention arm and kind of in the low 50s in the control arm. And this odds ratio crosses 1. It was 1.3 in favor of the intervention, but not statistically significantly different. So hot flashes decreased over time for both groups, but the proportion with hot flash improvement did not differ between survivors in the intervention and the control. On fertility-related concerns, we saw 52% of those in the intervention group now had low fertility concerns, and this was compared to about 30% in the control group. This comparison was significant, and this odds ratio just says that if you are in the intervention group, you have about 2.6 higher odds of having very low fertility concerns compared to those in the control group. So we said 53% of survivors in the intervention group had lower fertility and pregnancy-related concerns during the study, and that they had higher odds for improvement compared to survivors in the control group. We have some thoughts as to why we observed this, but this was a very exciting finding for us. For vaginal symptoms, this is the same format as hot flashes, where the vaginal symptom score is here described for blue for the treatment and red for the control. And you can see that over the course of 24 weeks, they really overlapped. So the odds ratio was 1.3 when you compare the intervention and the control group. Overall, the vaginal symptoms really didn't change in terms of the score for both groups, and it didn't differ between the intervention and the control group. And then finally, with regards to contraception, a minority of survivors who were not trying to become pregnant were using highly effective birth control methods. But throughout the study, these proportions did not differ between survivors in the intervention and the control group. So in conclusion, we deployed a very low-cost, web-based intervention. And by doing so, I think in both arms, we improved clinically significant reproductive health issues for a good proportion of young breast cancer patients who participated in our study. But the effect was not statistically significantly different between those who got the full skipper versus those who received access to the list of curated resources. So every time you do a study, it's kind of cool that you end up with more questions sometimes than answers. Our questions are, and this is a good point for discussion, do we feel like these data are strong enough to distribute the materials? If the materials are distributed, how, where? How could we improve this? Because ultimately what we did was to deploy access to web-based educational resources. And we know that it's going to take more than access to information in order for actions to happen. So an example would be, if there are concerns about a narrower window of fertility because chemotherapy depleted some of the finite eggs that each woman has, well, is having that information enough? It's a step, but how can we deliver the next steps for support? Like, how do we get a young patient who is interested in talking with a fertility person about the window of fertility post-treatment? What other things, aside from giving a website, can we do to support that action of seeking the health services that they need? And then we also, at the end of the study, asked for feedback, and we curated some of the responses to share with you. So these are some of the quotes that came from participants of the study, both sort of very favorable qualitative data, as well as too many hot flash text messages. I think 3 times a week would be okay. And actually, importantly, one of the things that we learned, which will go into our next studies, because we had a section on sexual health and how to improve sexual health. But because not only could you access the web-based information, but some reminders for how to improve your symptoms would come through text messages. This was one of the comments which was taken very seriously by us. If you're going to send text messages with sexual health content, I would suggest that you send them at a designated time so users are expecting them. If they show up randomly, other people might see them on your phone, which would be awkward. So I think that this was a really wonderful experience for us to be able to partner with multiple groups. I wanted to acknowledge our breast cancer advocacy partners and all of our participants. There's just no way that we could have done this study without feedback. And I wanted to introduce you to our co-investigators. So Diana Chingos is a young breast cancer survivor, and she is a patient research advocate from the Young Survival Coalition. Jenny Aaron is also a patient research advocate from Komen of San Diego. Mike Critchman is a sexual health OBGYN physician, and he is up in the Irvine, Orange County area. June Mao is at Memorial Sloan Kettering and is a primary care integrative medicine physician who does clinical trials on hot flashes. John Pierce is a health behavior researcher here at UC San Diego with me, and Loki Natarajan is our study statistician also here at UC San Diego with me. And then finally, for those of you who don't live in San Diego, I wanted to show you our research team. This is what we do. So I don't even know how to say how incredibly grateful we are for this opportunity for this project, because this project really brought together not only those senior investigators that you saw on the prior page, but a team of undergraduate students, medical residents, OBGYNs in training, fellows, public health individuals. And these are all the students and trainees who played a role in helping us conduct the study along with you. So thank you very much, and we are here to answer questions as Shaylin Stark, who is our project manager, and Emily Myers, who's one of our study coordinators. They're here. This is Emily. This is Shaylin. They're in the room with us, with me, here in San Diego. So we are really happy to answer questions, and this is bubble soccer in case that's the question.
All right, thank you so much, Dr. Su. So now we're going to take some questions. As a reminder, you can still submit questions through the questions pane in your attendee control panel. I'll start off with a question or two from Leah, and I'll hand it over to you, Leah.
Thank you so much for the presentation. This is really exciting and very, very cool data. I know for some of the studies we've done that we run into a problem with just a lack of diversity and making sure that the study is applicable to people outside of, the white women who sign up. So I just wanted to see if there were any plans to try to increase the diversity of the participants.
That's a great question. I think that one of our next steps is if we feel, and this is where feedback from the group would be awesome, if we feel like these intervention materials, so first we're going to go back and engage the participants of the study to do some qualitative studies to really understand what of these materials are relevant and what are not. And then in this effort, not only will we try to oversample for the patients who are not in the majority in terms of the demographic characteristics. We also in San Diego were approached by sort of farther outlying communities and care settings, including some in our South Bay, so closer to the border between Mexico and the US, with a larger Hispanic population, to basically see is this intervention or some version of it relevant. And I think that our next studies likely will focus on the fertility area because that's where we saw the most improvement, and it will be in collaboration with some of these other organizations that have better outreach to underrepresented communities.
Well, that's great. That's great. So the only other thing I wanted to talk about that I thought you might be able to explain a little bit more is if you could go back to the slide where you were talking about just the overall intervention and the p-value. I thought it might be helpful to talk to everybody who's listening because, like you were saying, the p-value is close to being statistically significant, and I'm not sure if everybody on the call will know what number you're looking for and kind of what that means. So I thought you might be able to talk about that a little bit.
Oh, great. So the p-value, so it's the idea of saying there is always the possibility that when you find a difference between your two groups, so in this case, it means that a difference between the intervention group and the control arm, what's the likelihood that it's a false positive, that it was a random association that we observed? And traditionally in clinical trials where you're looking at one outcome, that p-value is 0.05 or less to be considered statistically significantly different. So what that's saying is that as researchers, we own that if we saw a difference, that 5% of the time this was a false positive, spurious difference, that in truth, there is no difference between the two groups. But you can imagine that that 5% is sometimes a fairly arbitrary line in the sand. And so what you're looking for is how confident are you that there is this difference? So, and then I want you to chime in to help me like in another way, or Shay or Emily. But that odds ratio of 1.8 means that the intervention group has a 1.8 fold higher odds of improving compared to the control. But that 95% confidence interval means that if you did this experiment 100 times, that that your number will lay, that odds will lay somewhere pretty close to 1, which means no difference between the two groups, up to 3.4-fold higher in favor of intervention.
Great.
Anybody else?
And so I think it helps though to take it all into account, because I love that you included some of the comments at the end from the participants about what they thought about the materials, because if you have some materials that people are going to relate to, then that's great and something that could be worthwhile to pursue. So thank you for answering that question.
You are welcome.
So we have a couple of questions from a few Army of Women members. So first is a kind of general question. After the study, this member was hoping to learn more about what the next steps are in terms of the research that you're looking to pursue based off of these results.
Yeah, so I alluded to a few minutes ago that the goal is, so with feedback from our stakeholders, so that's going to give patients and healthcare providers kind of a debrief after this trial. If we feel like this material is compelling, then it gets disseminated on the web, through, if you guys have a place that you want to house it, in addition to other advocacy groups that maybe their members would want to see this information, we are very, very happy to just share it whomever wants to see it. But more importantly, I think that there's a whole new discipline of science called implementation science. So it is that you can do a trial, and if you find an effect, but now how do you get that information out? So I think that in terms of research, we are very interested in undertaking implementation science research on how do we get this into clinics, and the easiest places to do that are really in our region, from both this tertiary care Morris Cancer Center at UC San Diego all the way to federally qualified health centers in our outer lying community. That is where I think our research is going next. But of really sort of also excitement is, I don't know if you guys have heard of the Childhood Cancer Survivor Study, but it is a 26 institution study in the US that has tracked kids who are survivors of childhood cancer for a long time, years and years, to understand what are the late effects of cancer treatment, for which fertility is also one of them. So I was able to speak with the investigators this week to show them some of the data from the breast cancer skipper, and they want to modify this for a trial in childhood cancer survivors. So this is what we're doing.
Very cool. All right. Thank you so much. That was really interesting to learn about. I have another question from a member who was actually interested in kind of the logistical side of the study. So from idea to finishing collection of all of the data, what was the timeline for the study? How long did everything take?
So let's think back. So from the time, so when we were funded by the California Breast Cancer Research Program, we had just this idea. We had already generated the reproductive concerns after cancer scale, but all study materials were new from the point of funding. So it took us about 15 months to do the systematic review, and that's with a, I would say, moderately sized team. It took us about 6 months then to build the intervention. So that takes us to about 2-year mark, right? And then it took us about a year to recruit all of the patients and 6 months to follow them out. So we are talking about, this has been about 3.5, right? Am I at about 3.5? And then the analysis has been for the past 6 months. So a 4-year from beginning to finish. And sorry, finishing means the primary manuscript, the primary way of reporting out the data is done now, but our data set is actually really rich for all kinds of other sub-questions that we asked about these symptoms. So we plan on analyzing these data and getting the information out there for the public.
Great, great. And then we have not a question, but a comment that I wanted to share from one of our Army of Women members. This member noted that they would have really benefited from something like this, mentioned that they had a lot of fertility questions and birth control questions, and nobody seemed keen to speak with her. So she got the information, but only because of her own personal advocacy. So she just wanted to extend a thank you for the work that you're doing on this.
I think this is why we did this work, because clinically, our team really saw this need in really young cancer patients and survivors. So thank you for saying that it's irrelevant. But now we just need all of your feedback on how to make this better. This is the first go at this. So I think, and it's been probably a couple of months since I've done this literature search, but I think that this is the first trial to try to use an educational intervention deployed online to improve the reproductive health needs of young breast cancer patients. So this is the first go. There's going to be a lot that we learned. Any comments for how we can make this better, please send our way.
Excellent. Okay, so I think that is it for today. If you have any questions that we didn't get to, or think of new questions, or have any feedback to pass on, please feel free to contact us at connect@armyofwomen.org. We'll post a recording of this webinar on the Army of Women website in a few days. So on behalf of Dr. Susan Love Research Foundation, the Army of Women, and everybody, thank you so much for joining us today, and I hope you have an amazing rest of your day.
Thank you so much.
Thank you.